Today we will be discussing antenatal care. The term antenatal, literally ante, before, natal, birth. So antenatal applies to events occurring basically while a woman is pregnant and before birth of the baby. So antenatal care, which is the topic of today's presentation, is basically the management of a woman's pregnancy. Why is this concept important? All women should be offered at least a minimum standard of care, irrespective of their circumstance. One of the main objectives of us managing a woman's pregnancy, seeing her when she comes for clinic visits, is basically to identify those women who have risk factors, so things about them or their pregnancies or their babies which basically would need a greater degree of care, more focused and planned care, the so-called high-risk patient. On the other hand, we still want to recognize that a certain category of patient would need as intensive care, and these people that need that minimal level of care will be termed low risk. But we should always be mindful that the need might arise, even in low risk women, of escalating their level of care should problems arise. So, unique to antenatal care is the concept of booking. Booking refers to the first antenatal appointment. So the woman shows up to be seen in a pregnancy. We call that appointment the booking appointment. Usually, the person who conducts that booking visit is going to be maybe a general practitioner or midwife, somebody experienced in the management of women in a low risk setting. And the booking appointment generally sets the tone for the rest of pregnancy, so it tends to be regarded as one of the most important visits for the pregnant patients. Recommendations coming out of the UK, NICE guidelines, which recommend that your booking appointment should happen in the first trimester before the woman has reached 12 weeks of pregnancy. And this assures that measures are put in place that the lady achieves the required level of care from early in the pregnancy. At this booking visit, we could arrange for her to have a booking ultrasound. And this is generally recommended by NICE to take place between 10 weeks and 13 weeks, so just at the end of the first trimester. The reason for doing this is so that we don't, end up doing multiple scans for the patient. For example, if we were to do a really early ultrasound at say 6 weeks, 5.5 weeks, we probably could ascertain that there's an intrauterine pregnancy, but we'll get the more information if we wait just a little bit. Pretty accurate information about the diagnosis of multiple pregnancy. If we can wait to 10 to 13 weeks, we should be able to see number of sacs, number of fetuses, and we'll get a bit more of information about scans for multiple pregnancy in our ultrasound tutorial. But the first trimester is also a good opportunity to estimate the date of delivery and the current gestation from an ultrasound, as those first trimester ultrasounds are the most accurate timing for ultrasounds. You get a scan before the influence of genetics, which will make a human big or small according to their family history. If you get that early trimester ultrasound, the influence of genetics is minimal. You get a more accurate assessment of fetal size, regardless of family history and background. It's also a good opportunity to assess pelvic masses, for example, uterine fibroids, ovarian cysts, which are a bit more difficult to see when you have a large pregnancy taking up a lot of the scan field in later pregnancies. As I mentioned, a lot of this information can be seen in the ultrasound lecture. So aside from arranging the ultrasound assessments and so on, there are also some other objectives of the booking visit, that first visit, you're going to it's going to be a good opportunity to provide the woman with information, education, which can help her to understand what to expect throughout the course of pregnancy. It's a good opportunity to identify pre-existing health or social problems, for example, domestic violence for the social problems, health problems, diabetes, asthma, and so on, right? Which again would reflect her level of risk. Review her obstetric problems in addition to her medical problems. Review her lifestyle issues, smoking, alcohol use, and so on. Check her family history, because certain family history elements do predispose to problems in pregnancy. For example, a strong family history of diabetes might implicate risk for gestational diabetes, or hypertension, a risk for gestational hypertension or preeclampsia. And that booking visit is also a good opportunity to counsel and perform some screening tests. Right. So we get next into identification of risk factors. So identification of women at high risk of venous thrombosis, that's a good thing to do. So you want to know those ladies who would have risk of things like deep vein thrombus, pulmonary embolus, and you probably would want to be able to ascertain whether or not this lady is someone who would need to receive thromboprophylaxis or preventive measures against clots during or in the pregnancy or immediately after. So there should, in the ideal scenario, be in the early pregnancy a documented assessment of risk for venous thromboembolism, such as outlined in the Royal College of Obstetrics Gynaecology guideline on this topic. So depending on the risk factors which the lady exhibits, whether in her past medical history, her physical features, and so on, we might need, as we said, as a preventive measure, to prescribe low molecular weight heparin is a usual way of preventing those blood clots. Okay, so this is taken from, as we mentioned, the Royal College of Obstetricians and Gynecologists. We call them RCOG for short, guideline. And there are some pre-existing risk factors for blood clots, deep vein thrombosis. Clearly, if she's had a clot in the past, that's a big risk factor. If she has thrombophilia or tendency towards getting clots, such as she's inherited certain disorders, we know antithrombin does prevent thrombin formation in clots. So if she has a lack of antithrombin, that's a risk. Protein C and S, which are also anticoagulant, she has those missing, she's at risk. Prothrombin rotation, factor 5 laden, those are all inherited. There are also some acquired ones, such as antiphospholipid antibodies, right, which is antiphospholipid syndrome is a condition which can cause pregnancy loss, can cause clots, can also cause things like preeclampsia. So we're quite wary of antiphospholipid, in which case it might have these things like lupus anticoagulant, anticardiolipid antibodies, or beta-2 glycoprotein 1 antibodies in their blood, right? So antiphospholipid syndrome is a thrombophilia, and these people would need to have low molecular weight heparin. Also, people with things like cancer can cause clots. Heart failure can cause clots in the heart and strokes. Active SLE, other conditions, nephrotic syndrome, type 1 diabetes, nephropathy. Sickle cell is a good one. Sickle cell obviously can cause slowing of the blood flow in blood vessels. That's a risk factor for thrombophilia, somebody that might need thromboprophylaxis. Older woman, so age above 35, the more likely is she had a thrombus. Heavy women, ladies with a larger BMI, because I guess they're more sedentary, because there's more weight and pooling of in the peripheries, more stasis, again a risk factor for thrombus. And this is either pre-pregnancy, that BMI, or even if they're early pregnant, you get a BMI above 30, that's a risk factor. More than 3 deliveries, risk factor. Smoking, because of damage to blood vessels and so on. Varicose veins, again more stasis. Paraplegia, more stasis, are pre-existing risk factors for thrombus. So the college has said that if 4 or more of those, 4 or more exist, then this woman would need to have that low molecular weight heparin injection administered throughout her pregnancy. So she would need to actually teach herself how to give this injection, and also for up to 6 weeks afterwards. If she has 3 risk factors, then the first trimester will pass, the second trimester, from the third trimester onward, 28 weeks, which we count as viability in Barbados, onward until delivery of the baby, and then probably up to 6 weeks after the baby's born, 6 weeks postpartum. With 2 risk factors, you consider for at least 10 days after the baby is delivered. Okay, so just to recap that, very important to assess a woman's risk from the time she becomes pregnant of needing protection against things like deep vein thrombosis and other clots. And we do have a list of risk factors, either pre-existing or acquired, which can be assessed, and depending on the number of risk factors that are present, we would prescribe a longer duration for more risk factors being present of the low molecular weight heparin. Alright, excellent. So next important point, identification of women at high risk of hypertensive disorders. And this is a kind of important area, and one that we definitely look out for in pregnant women. So every time a pregnant woman comes to visit, we do check her blood pressure, we do check her urine dipstick. So preeclampsia is probably the killer, the more serious hypertensive disorder of pregnancy, which we're looking out for. And preeclampsia is characterized by 2 main things: high blood pressure and protein in the urine, proteinuria. And this, we tend to associate this midpoint of pregnancy, so after 20 weeks of pregnancy, with conditions which are pregnancy induced. So high blood pressure is pregnancy induced hypertension, but what if that element of proteinuria, so proteins in her urine, and that occurring in the second half of pregnancy, so after 20 weeks, will make the diagnosis of preeclampsia. So similarly to how we have risk factors for thrombus, we also have a list of risk factors for preeclampsia. And we would assume an increased risk of that if they have one so-called high risk factor, or more than one of the so-called moderate risk factors. So you have one high risk factor, that's all you need to say that you need to put preventive measures in for preeclampsia in place. If you have more than one, so 2 or more moderate risk factors, prophylactic measures need to be put in place. And for us, that prophylaxis tends to be low dose aspirin. So the woman would start to take aspirin and take that during the antenatal period from 12 weeks onward. So one of these high risk factors, of which you need one to put prophylactic measures. So if she's had hypertensive disease in the previous pregnancy induced hypertension, preeclampsia, if she has chronic kidney disease, if she has autoimmune disorders such as lupus, and we mentioned that antiphospholipid syndrome as a risk factor, type 1 or type 2 diabetes, and chronic hypertension. So we can see a trend here of diseases long-standing maybe, or in previous pregnancy for the hypertensive disease, which cause small blood vessel damage. Yes, kidney disease, autoimmune disease, lupus, antiphospholipid, type 1, type 2, chronic hypertension, all high risk factors will definitely need prophylaxis. So the moderate risk factors don't have that in common. Probably, first time mothers more likely to get preeclampsia. The older women over 40, if she's had more than 10 years between pregnancies, between this pregnancy and the last one, if she has a BMI greater than 35, so class 2 obesity at least. If she has a family history, not a personal history, because personal will be a high risk factor of preeclampsia, or she has multiple pregnancy. So she has 2 or more of these factors, or more than one, we've said before. So she's a 40-year-old prima gravida, for example, or she has a BMI of above 35 and she's pregnant with twins. That would be sufficient to say prophylaxis is necessary. So as we said, low dose aspirin, for example, a 75 milligram tablet from 12 weeks, and the NICE guideline says until birth of the baby. So we're mindful for both this and the thromboprophylaxis that, delivered baby, there is risk of blood loss, so you tend to be sensible in your prescribing, and you tend to say something to the lady along the lines of, should she go into labor, don't take your aspirin that day, or don't take your heparin that day, right? So preeclampsia risk reduction, low dose aspirin, and it reduces the risk of preeclampsia about 15%. If for some reason the lady books later, or the aspirin prophylactic measures institute later, the treatment is less effective. So ideally, you kind of want to have that introduced before she reaches 16 weeks. Next concept, identification and care of women with pre-existing medical condition. So women with other medical conditions obviously would merit early referral for specialist care. It's a clinic which has a consultant, so that they have access to multidisciplinary care. In the context of Barbados situation, this would mean referral into the QEH in the public setting, where there's access to specialists, maybe cardiologists, endocrinologists, and so on, where the obstetrician can lead the obstetric care, and there's access to other teams as needed. So on to antenatal care and education. So we want to educate the lady, as we said in our earlier bullets, on things like lifestyle. So we tend to kind of recommend that she stays away from alcohol as much as possible, because of the association with, in the first 3 months of pregnancy and when planning pregnancy, miscarriage. And the first 3 months of pregnancy is a critical point in the pregnancy for the development of fetus, and hence there can be fetal damage due to alcohols in circulation that probably associates with the risk of that miscarriage there, and things like fetal alcohol syndrome. So advice generally from the NICE guidelines is no more than 1 or maybe 2 at the maximum UK units, maybe once or twice a week. So we've got 1, 2, 1, 2, 1 to 2 units once or twice a week. No more than that. Certainly if we can avoid completely, that's maybe even better advice. Science and research hasn't shown a safe level, but clearly things like getting drunk or binge drinking more than 5 drinks or 7.5 units or 1 unit on one occasion can be a cause of fetal alcohol syndrome or fetal damage. And in case you're not familiar with what a UK unit is, it's basically maybe a half glass of beer, standard part glass of wine, etc. This is a pictorial sort of representation of what 1 unit is, and 1 to 2 units, 1 to 2 times a week is the maximum recommendation for women trying to get pregnant. Smoking. So again, as much as possible, we kind of recommend no smoking, and we would want the lady to know the risk of smoking to her unborn child and the benefits of stopping. So smoking, everybody knows about the risk of low birth weight, because smoking, clearly carbon monoxide in the blood binds with great affinity to hemoglobin, so that means that less oxygen is available for the fetus. Carbon hemoglobin kind of doesn't dissociate well, so that lack of oxygen reaching the baby means more likely to have fetal growth restriction and a low birth weight. So if she can stop, the sooner she can stop, the better it is for the baby's growth. So smokers, we tend to really pay keen attention to how the babies grow, maybe arrange sealed ultrasounds. There is also the risk of premature birth, risk of respiratory conditions, risk of things in later life in the baby, such as problems in the baby's ears, nose, throat, risk of childhood obesity, childhood diabetes, all associated with smoking in pregnancy. So as much as possible, we do recommend that the lady desist from smoking if she does do so. Diet. So we should, and women often complain that they don't get enough information on. We should really recommend to women what constitutes a healthy diet and the benefits of a healthy diet and healthy eating in pregnancy. Going on diets and plans to lose weight are not recommended during pregnancy, as this may result in harm for the baby. Yeah, certain amount of body fat and so on is necessary for sustaining the pregnancy. There are certain myths that are pervasive in culture which should be dispelled. So there isn't any need for the woman to eat for two. She's not needing to sustain two whole adult people. There's no need for her to drink full fat milk. So you really should explain to the woman that her energy requirements are not going to double. They don't really change that much in the first 6 months of pregnancy, and in the last 3 months, the third trimester, the requirement then increases, but not no more than 200 extra calories are needed per day. So eating for two, oh, wife's tale, don't do it. You might also want to provide her with some information about supplements. What can I take, doc? And if she's planning pregnancy, that's the best time to say to her, let's put you on a folic acid supplement, because this is necessary for development of the baby's nervous system. The neural tube tends to be closed by the time she recognizes she's pregnant. So the best time to have supplementation to reduce the risk of neural tube defects, and the chief examples of those, spina bifida and anencephaly. Those are reduced through institution of a policy of folic acid supplementation. So with low risk factors for neural tube defects, 400 micrograms is enough, or 0.4 milligrams, you might see it written. 400 micrograms is enough, and that's taken when planning pregnancy and up to the 12th week. So throughout the first trimester when the baby's organs are developing. In certain conditions, people might have higher risk factors for these neural tube defects. So, for example, obese women will have a larger volume of distribution for this folic acid, so they need more folic acid. Patients and partners, so the woman or her husband or partner, if they have a neural tube defect, or if they've had a baby with a neural tube defect, or have a family history of neural tube defect, that's a category of patient that would need this higher dose, 5 milligrams per day. So we do have 5 milligram tablets available in Barbados on prescription. So people of these categories would need that prescription rather than the routine antenatal vitamin, which would have in that 400 microgram. Also, diabetics would need more folic, and they are prone to fetal abnormalities during that period of development. Higher doses is suitable for them. And persons, epileptics, who are taking anticonvulsants, because anticonvulsants induce liver enzymes, increase metabolism, making less folate available for fetal purposes, purposes of rapid dividing cells in general. They would also need a higher dose, 5 milligram. I mean, even add to this list people that have rapid cell turnover, such as sicklers, who have hemolysis and destruction of red blood cells, would benefit from that 5 milligram per day supplementation. Iron supplements, though commonly seen and given and asked for by our patients, routine supplementation generally is not necessary and isn't recommended by major guidelines. However, you would need to supplement iron in patients who have evidence of iron deficiency anemia, which is the most common type of anemia in pregnancy, aside from the physiological dilution of the red blood cells. Exercise is a good habit, and you do recommend that ladies do continue to exercise during pregnancy. So we have two categories of women: people that might not have exercised routinely prior, and then we have women who might have been exercising regularly. So those who haven't really been exercising before, it can begin, and we would recommend for them get started gradually. Pregnancy, you're carrying extra load, you probably need more oxygen, and if you're starting to put on a too strenuous load too quickly, you might not be able to sustain or support it. So you would recommend for them maybe no more than 15 minutes of continuous exercise 3 times per week, but gradual increases as they become more tolerant to maybe 30-minute sessions daily, to 5 times per week, for example. Should she have been exercising regularly prior to pregnancy, then they should be able to continue with no adverse effects. But of course, certain exercises are safer than others in pregnancy. So recreation exercise, things like swimming, brisk walking, strength conditioning, or lifting light weights, probably safe and beneficial. But now is not the time for her to engage in scuba diving, which has increased oxygen hyperbaric levels of pressure and increased oxygen requirements. It's probably not a good time for contact sports like martial arts and so on that can cause trauma to the belly. So these are examples of safe exercises. So what should she avoid in terms of food? General advice: we want to avoid certain foodborne infections. Listeriosis is associated with effects on the fetus, passage of meconium and so on in utero. Fetal damage. That listeria can be found in things like soft cheeses, so ripened soft cheeses, blue vein cheese, pate, camembert, brie. Those are the types of cheeses we would tend to advise avoiding. Salmonella can also cause fetal effects that's present in raw or partially cooked eggs and meat, so we kind of tend to advise ladies to make sure that eggs and meats are well cooked. We also would want them to avoid using medication liberally without prescription or without conferring with their healthcare provider, because very few medications have been established to be safe for use in pregnancy with very few fetal effects. So basically we would tend to limit our medication use to when the perceived benefits of medications outweigh risks to the fetus. So the benefits for the mom outweigh the risk to the fetus. Domestic violence we mentioned briefly earlier, and this is basically in the home situations that might be unsafe for the mom. Abusive spouses or abusive others within the home, and this can be a significant contributor to maternal morbidity, maternal death as well, and can have consequences for both mom and baby. So it is a kind of a touchy situation, and women might not open up much about it, but some sort of sensitive way of maybe asking, or maybe being mindful of perhaps the interaction between patient partner at booking visits should be paid attention to. If at all able to detect mental health problems, that's a good thing to do at the booking visit, because if patients with past or current mental health problems, depression, psychosis, there is an increased risk of adverse pregnancy outcomes. So specific inquiry is recommended to identify women who have a history of severe mental health issues. With respect to detecting depression, which is a risk factor for things like self and fetal harm, there are some screening questions which are commonly used both inside and outside of obstetrics. So there tend to be 2 main screening questions with a third added should the answer be yes to either of the first 2. So first one is, during the past 1 month, have you been bothered by feeling down, depressed, hopeless? And the second one is, during the past month, have you often been bothered by having little interest or little pleasure in doing things? And if there's an answer of yes to either one of those, so the anhedonia is present or the feeling down is present in the past month, then you ask them, basically, is there something you feel that you want help with? And should you have a yes to that question, then the next step is to engage mental health services. in a multidisciplinary discussion. So at the booking, and certainly throughout pregnancy, you might encounter some minor ailments of pregnancies within the patient complaints. So nausea and vomiting, pretty common in early pregnancy, and that's due to rises in the placental hormones and the hormone HCG. Right? So HCG is what's commonly tested to confirm pregnancy, either in urine pregnancy tests or quantitatively during blood tests, and the rise in that hormone, as well as things like estrogen, can cause nausea and vomiting in a woman. Because the levels of those hormones tend to plateau, most cases of nausea and vomiting due to pregnancies alone would tend to resolve by 16 to 20 weeks, even without medication being used. Some interventions which have been shown not to be associated with harm would be things like use of ginger, so things like in ginger snaps and so on. Reduces nausea. Acupressure, PCY6 or P6 acupressure, is pressure on the inner wrist between the two tendons, about 3 centimeters above the wrist. That's been shown to reduce nausea. Antihistamines, so usually histamine 1 receptor blockers, things like dimenhydrinate, so that's in your quote Gravol brand name, or Dramamine, or things like in diphenhydramate. Cyclizine is probably more commonly used in the United Kingdom, and things like antacids for heartburn, such as your calcium carbonate and so on, can help to reduce the nausea and vomiting symptoms. Varicose veins, another fairly common ailment because of increased circulating blood volume, increased dilatation of blood vessels in response to progesterone, increased pressure from lung standing and so on. Pretty common, and these tend not to cause harms in most situations. The symptoms of these can be improved, if necessary, with use of compression stockings to improve venous return. Vaginal discharge, again, something fairly common, and physiological discharge is due to rising levels of hormones such as estrogen, causing secretions from the vagina. But vaginal discharge, though commonly physiological, can also be pathological, such as due to infection. So you suspect pathology maybe if you have itching or odor and or unusual color, green or turbid. And should you suspect infection, then you should investigate to suit, maybe some swabs, and treat infections as appropriate. Backache, another common ailment of pregnancy due to mechanical concerns, standing, enlarging tummy, and things like acupressure, massage, physiotherapy may help. Simple analgesia, positioning. So we're on to now to clinical examination. So generally speaking, we think of clinical examination as general examination by systems, and specific to obstetrics, maybe the abdominal and pelvic assessments. When it comes to cardiovascular system, the majority of women, maybe 80% or more, when they're pregnant, because of increased circulation, expansion of the blood volume, increased cardiac output, the turbidity of flow leaving the heart can result in an innocent murmur called a flow murmur. And this can be heard in up to 80% of women at the end of the first trimester. Because of that, it's probably not necessary in most cases to listen to heart sounds, because detection of murmur can lead to anxiety and over-investigation. Should the woman, however, be known to have a murmur or cardiac concern prior to pregnancy, appropriate examination should occur, and specialist referral for multidisciplinary care by obstetric medicine specialists and maybe cardiologists, as we mentioned, is appropriate. Part of your general examination, maybe thyroid breast examination, formal breast examination is not often required. The patient probably would understand and know her own breast better. So self-examination is probably just as reliable as a physician examination, and the woman should be encouraged that should she find some change, like an unusual lump or new suspicious, that she should report it. And this should be taken seriously by the clinician, not delaying investigation simply because the lady is pregnant, because breast cancer pregnancy can occur. It's very often delayed, and that can be to the detriment of the patient. So, new lumps found by the woman at her own self-examination should be reported to the obstetric or antenatal care provider for further evaluation without delay. Routine pelvic examination, again, something which has gone out of fashion because some women actually have concerns that this can precipitate problems with the pregnancy, miscarriage. Some women might feel uncomfortable with the examination, and if you're doing a transvaginal ultrasound assessment before booking, at any rate, you're likely to pick up major pathology and have evaluation of things like fibroids and so on. So routine examination tends to not be recommended nowadays, particularly if ultrasound is planned. Abdominal palpation. Routine examination could be a crude screening tool. So if you have an idea of how far along the patient is meant to be, should the pelvic mass be larger than expected for dates, for example, you might have suspicion of things such as maybe multiple pregnancies, so twins or higher, or wrong dates, which can be large as well. But round dates can also be small. And when I say round dates, I mean that perhaps the lady's last period wasn't remembered correctly or wasn't reliable. Maybe she had a irregular cycle. So small for dates pregnancy might be a sign that maybe the pregnancy is failing, i.e. miscarriage. Right. Large or small could also be due to things like molar pregnancies or so on. So should you, on your crude screening tool, your routine abdominal palpation, find a large or small fetus, it might be an appropriate next step to use an ultrasound to ascertain the cause of such a discrepancy. Maternal height and weight, pretty important at your booking visit, as a BMI, a low BMI, one below 20, and we mentioned body fat being supported with fetus before. Low body BMI, higher risk of fetal growth restriction, higher risk of perinatal morbidity. Right, fetal growth restriction means failure of the baby to meet its genetic growth potential. So the baby is growing slower than you anticipated, and here low BMI is a risk factor. On the flip side, a BMI above 30, so in the obese range, also presents quite a few risks. So that would prompt a discussion on the risk of obesity to the health of both mom and the baby, maybe advice, refer to a dietitian to get advice on healthy eating so that she limits her weight gain. And we kind of want her to not gain more than 5 to 9 kgs in the pregnancy if she has such a high BMI. And between pregnancies, we would encourage weight reduction in order to reduce her risks. And here are some of the negative effects of maternal obesity for your perusal. More difficult to get pregnant, more risk of miscarriage, gestation diabetes as insulin resistant condition is increased, perinatal complications, so larger mums tend to result in larger babies, shoulder dystocia, a bit short when the shoulder doesn't deliver well, postpartum hemorrhage is a risk, and so on. For the baby, there seems to be increased risk of stillbirth, metabolic abnormalities from that phenomenon we know as programming. So bigger moms tend to have childhood obesity, as sort of thing, childhood diabetes, hypertension in the offspring, and so on. Right, all that's mentioned there. Should the BMI be normal at your booking assessment, there seems to be no benefit to repeated weighing during the pregnancy, and this can be dispensed with. What is routine, however, is blood pressure evaluation. So we get her at booking. Earliest we can see, it's good to have an idea of what this lady's blood pressure is like. And blood pressure tends to be lower in pregnancy because of relaxation of blood vessels under the influence of progesterone than outside of pregnancy. So if you get a first blood pressure in pregnancy, that allows you to reckon basically if this lady seems to have long-standing hypertension or if she's more normotensive at booking. And then this has implications for assessment later on. So should she have blood hypertension, as in at least a 140 systolic or a 90 diastolic on 2 or more occasions, at least 4 hours apart, then we should look for a secondary cause of hypertension. Right? So first time early pregnancy, more than 140, 90 on 2 or more occasions, 4 hours apart, that's hypertension. You probably should look for underlying cause, as hypertension in pregnancy is not common in reproductive age women, young women, and so on. Urinary assessment. A midstream urine is a useful investigation at the booking appointment. It's meant to screen for infection, asymptomatic bacteria in this case. So bacteria within the urine, but without the usual, dysuria or frequency associated with an overt UTI. And the reason for trying to detect this is that if you have bacteria there, despite no symptoms being present, due to hormonal concerns in pregnancy, stasis, a mass compressing the bladder and compressing the urinary system, dilation of ureters as a result of progesterone and that compression, you have more chance of infection rising from the bladder and into the ureteric and the pelvic calyceal system. Pyelonephritis, right? And untreated infections also risk pregnancy loss, miscarriage, preterm labor. So, useful screening tool, useful to treat asymptomatic bacteria before it results in pregnancy complications. Urine dipstick, commonly done, booking and throughout pregnancy. She has proteins in the urine, that's not usual. Blood in urine is not usual, so persistent protein urihematuria might trigger look around for underlying renal disease, prompting further investigation. So far so good, so we're on to booking blood tests. So there are certain tests which we would do at the booking appointment, and there are certain others which are timed according to the gestation and done later in pregnancy. So just a word about gestation diabetes screening. So there are a certain category of women who have higher risk factors for gestational diabetes, and these are probably women that should be screened at booking as opposed to routine screening at 24 to 28 weeks. So women with a BMI above 30, more insulin resistance, probably should be screened after she's had a baby with a weight 4.5 kilograms or more. That's a big baby. Fetal macrosomia probably should be screened because that is a risk factor for having had that. If she's had gestational diabetes in the previous pregnancy, and she has a strong family history in first-degree relatives, so 1 degree of separation, maybe a mother, a father, a sister, a brother, a cousin, that's another indication for early screening. Also, well, here we are in the Caribbean, but people of South Asian, like Indian, Pakistani descent, Arabs, and so on, higher risk factors. And this list comes from Antenatal, the NICE guidelines, Antenatal Care, published in 2008. So should they have these risk factors, they recommend early screening, somewhere around 16 to 18 weeks, especially if she's had gestational diabetes previously. And if that screening test is normal, because of that rise in hormones, progesterone, human placental lactogen is causing pregnancy to be what we call diabetogenic, or makes blood sugar rises more likely. That is recruited at around 28 weeks if the first test was in fact normal. Should she have not had any high risk factors, then the usual screening time, the routine screening time, is 24 to 28 weeks for your gestation diabetic screening. Booking, we also would do certain hematological investigations. For example, we do screen for anemia. That screen involves taking a hemoglobin assessment. If hemoglobin is pathologically low, so we have pathologic anemia, majority of the time it will be iron deficiency, such as we mentioned before. Unlike outside of pregnancy, because of that physiological dilution of red cells, so both the plasma volume in circulation and the red cell volume do increase, but the plasma volume increases at a faster rate. We would expect that lower thresholds for diagnosing anemia are present, and the greatest dilution effect is in the second trimester, so we expect that the hemoglobin will be lowest at that point. So a lower limit of hemoglobin in pregnancy of 11 grams per deciliter is acceptable in the first trimester, and after that 10.5 grams is the lower limit of acceptable hemoglobin. So we tend to perform screening at the booking assessment, but again at 28 weeks where we expect to have our hemoglobin at the lowest, and perhaps again at 36 weeks when we're planning delivery. Hemoglobin levels outside normal range, as in low hemoglobin, anemia, should be investigated as appropriate and treated. And should the 90% iron deficiency be the diagnosis, then the usual treatment is with ferrous sulfate as an iron supplement, 200 milligram tablets. Next, hematological investigation, which recently has been done to all the pregnant women coming for treatment in Barbados for antenatal care, is screening for sickle cell anemia. And whereas in other places they might do things like HPLC, which is high performance liquid chromatography, we tend to use an older method called hemoglobin electrophoresis, which uses electrical currents to separate hemoglobin in bands, and this allows us to determine whether the patient has adult hemoglobin A, if the patient has maybe a sickle trait like a S or a C trait, etc. So doing this universal screening allows us to identify a mom who might have a trait that she might not know about, so we can give advice to at-risk couples. So should the dad also carry a trait, then there's a risk that the baby has maybe a full-blown sickle disease. So it allows us to identify couples at risk, screen the partner when necessary, and aim for decision making. We're not done with hematological investigations yet, as we also need to check blood group and rhesus. And if implicated, unlike other places where it's universally done, antibody testing can be done as well. So key importance here is to identify patients at risk of fetal hemolytic disease, so destruction of fetal red blood cells. Rhesus negative mothers would naturally see a rhesus positive antigen in their blood as foreign. So should they carry a rhesus positive baby because their partner is rhesus positive, then in the event of certain sensitizing events or in the event of delivery, we would plan that the woman could need to receive some anti-D immunoglobulin. This is an injection. It is meant to bind D antigens prior to the mum recognizing it as foreign in order to prevent sensitization. So that can be prescribed and given once the mom is not sensitized in certain situations. To identify the risks, we do, of course, check the partner, because a rhesus negative dad with a rhesus negative mom would usually imply a rhesus negative baby and no need for prophylaxis. Should the mom have been sensitized in the past due to miscarriage and no prophylaxis, or ectopic and no prophylaxis, or etc., then there might be a role for checking this current baby to detect whether this baby is suffering from that hemolytic disease we mentioned, which can result in fetal anemia. So there are non-invasive methods of that using ultrasound, such as the middle cerebral artery Doppler, and fetal anemia can be treated with fetal blood transfusion or early delivery plan should things get to that level. So yes, blood group and rhesus antibody testing, quite important. Rhesus testing and antibody testing, such as the indirect Coombs test, which will be positive if sensitized, is important at booking. Nowadays, we're also doing rubella immunity screening, and it's important for us to recognize that though this test is positive, that's a good thing. So we'd expect that mums would have had during their childhood vaccination against measles, mumps, and rubella. So a positive test means that she has rubella IgGs in her blood, which means she's immune, which means that she should not be able to contract rubella. Because if she is negative, that means she is susceptible, which means that if she were to contract rubella while pregnant, that baby is at risk for certain defects. Rubber ducky, I'm so blue. So rubella is associated with things such as patent ductus arteriosus and eyes, ears, heart, cataracts, sensory neural deafness, and as we mentioned, PDAs and other heart defects are common with rubella, right? So the conventional advice, if she is rubella naive or has a negative test, is avoid contact with anybody who has a rash in pregnancy. And also, once she's delivered the baby, we can administer vaccination. We don't administer vaccination in pregnancy because the MMR is a live vaccine, and live vaccines could sometimes result in full-blown disease. And as we said, rubella can cause congenital rubella syndrome, so it's avoided. We also now routinely screen everyone for chlamydia infection, and the way we do it locally in Barbados is to do a first catch urine for polymerase chain reaction, or PCR. We tend to do it along with the gonorrhea, so that should the woman be found positive, treatment can be instituted to reduce the risk of things like miscarriage, and certainly later in pregnancy we know that these conditions can cause eye concerns, congenital conjunctivitis, and so on. So we do routinely screen, treat, and re-screen if necessary, and both diseases would require co-treatment of the partner. In the UK, their screening guidelines are a bit different. They tend to find the 25 and under age group to be at higher risk, so they tend to screen exclusively in that group. Syphilis is also one of the things we screen for, and the screening test would either be a VDRL, or Venereal Disease Research Laboratory, or RPR, Rapid Plasma Reagent. So these are screening tests, which means they can be applied widely to a number of patients at low cost, but it also means that they're not definitive, as in you can't make a diagnosis from a screening test alone. So a positive screening test would need a confirmatory test, right? And for the confirmatory test for syphilis, we do check for either antibodies against the Treponema pallidum organism, or look for the organism itself. Okay, so in Barbados we use what's called a Treponema pallidum particle agglutination assay, or TPPA. Although in other places you might see a TPHA, or Treponema pallidum hemagglutination assay, or FDA-ABS, which is fluorescent treponema antibody absorption test being done to confirm. right? We're mindful that there are false positive VDRLs in autoimmune conditions, and even pregnancy can cause a false positive. So all positive tests must be confirmed before instituting any treatment. Hepatitis B also now universally screened, as measures can be put in place if it's detected to prevent mother to child transmission. And that's done through both passive and active immunization for babies. So we will give them hepatitis B immunoglobulin for passive, and then we immunize them so they make their own immunoglobulin by giving them the hepatitis B vaccine, the HIP, at birth. Right? So we screen because we can minimize transmission. HIV also routinely screened because, again, we can minimize transmission. So detecting HIV and instituting measures such as cesarean section if necessary for high viral loads, institution of highly active antiretroviral therapy, and avoidance of breastfeeding have reduced transmission from 20% to less than 2% now. So appropriate management of HIV in pregnancy can reduce mother-child transmission, hence we screen everyone. Group B streptococcal screening has now become almost universal in Barbados, and the role here is to reduce the perinatal transmission of this bacterium to the baby, which can cause sepsis. Early onset neonatal group B streptococcal sepsis is a devastating sequelae of this bacteria. So screening at 35 to 37 weeks, we say on average 36 weeks, with low vaginal, so low in the vagina, it doesn't have to be up by the cervix, it's low vagina and in the rectum. We send that off, and a positive test would implicate antibiotic prophylaxis with a penicillin in labor, or something like a clindamycin or gentamicin if the lady is penicillin allergic. So screening is meant to reduce infection through treatment in labor. So if the lady is swabbed or has a midstream urine for another reason during pregnancy, group B streptococcus is detected, this same sort of treatment in labor is instituted regardless. Toxoplasma, not routinely screened for, though it can cause fetal birth defects, but we do advise women, similar to how we talked about diet earlier, to avoid things that can cause them to get toxoplasmosis. We know now that toxoplasma is present in the cat as a host and in cat feces, so we recommend that they wash their hands carefully after gardening and handling soil where feces might have been, thoroughly cooking raw meat, keeping the cat away from the meat, avoiding cat feces, kitty litter from the soil. We make sure they wear gloves, and thoroughly washing their fruit and vegetables before eating. So we can talk next about screening for abnormalities of the fetus, so structural anomalies. So fetal anomaly screening assesses whether the fetus could develop or already has developed some sort of abnormality or condition in the pregnancy. Screening techniques will include having a look at the baby, such as ultrasound, doing blood tests, or some combination of the two. The routine anatomical survey using ultrasound for fetal abnormalities is generally recommended between 18 weeks and the end of the 20th week. So 18 to 20 weeks. So 18 plus 0 to 20 plus 6. Should the abnormality be detected, there is a role for counseling of the patient so they know what to expect, or even for termination of pregnancy while it's still allowable by law, thus reducing perinatal morbidity or allowing anticipation of issues which can potentially be corrected. For example, congenital heart disease could be fixed by cardiothoracic surgeons at birth, or by fetal surgeons in utero. Gastroschisis, which is basically an abdominal wall defect, can also be planned for and corrected in the early neonatal period. Next, common issue with anomalies is a chromosomal abnormality known as Down syndrome. So we can screen to identify women at risk for Down syndrome. Age is a big risk factor, so the older the woman, the more likely is she to have errors in transmission of her genetic information, as the eggs have been held in meiosis for a longer period. So non-disjunction, which means failure of the chromosomes to separate in meiosis, is more likely to occur, and hence extra chromosome numbers, Down syndrome. So age is a screen, but very often we can do blood tests to assist with screening, ultrasounds, and so on. So one option for screening is what's called the combined test, which takes place near the end of the first trimester, so between 10 weeks and 14 weeks and a day. And this has a detection rate of 85%. It is a kind of triple or three-pronged test, and it involves one ultrasound investigation, and that's checking the nuchal translucency, which is basically the amount of fluid behind the neck of the fetus. So you will see a space area behind the fetal neck, and that's measured, where thicker thickness frequency is more associated with Down syndrome. And there are two blood tests. So the human chorionic gonadotropin, HCG, beta-HCG, and the PAP-A, or pregnancy-associated plasma protein A. So taking these three measurements together, two blood tests and one ultrasound test, can give us an 85% detection rate of Down syndrome. Later on in pregnancy, screening can also take place. This is something called the quadruple test, and this can take place between 14 weeks and 20 weeks. This has a slightly lower 80% detection rate, and with the quadruple, 4 bloods are taken, although in Barbados more commonly you might find a triple. Right? So HCG, alpha fetoprotein, or AFP, unconjugated estriol, UE3, and inhibin A, or the 4. And how I tend to remember this is high and low. So 2 of them are high, and 2 of them are usually low in Down syndrome. High HCG, inhibin A, these 2 are higher in Down syndrome. Low, maybe it's a stretch here, the L and the O, estriol, these tend to be low in Down syndrome. So on to curing later pregnancy. Monitoring of fetal growth. 2 clinical methods are used for assessing fetal growth. One is symphysis fundal height measurement, so measuring with a measuring tape from the symphysis pubis to the fundus of the uterus, and this one is recommended from 24 weeks onward at every antenatal visit. And that judicious measurement improves prediction of small for gestational age neonates by detecting symphysis fundal heights which are smaller than expected. Abdominal palpation, probably not routinely performed. So some people clinically with feeling an abdomen might be able to determine how large they think the baby is, or how small. So that has limited accuracy clearly, and not routinely performed in this context. So this demonstrates how symphysis fundal height measurement is done. So we've got symphysis pubis. You're going to place part of the tape here at the top of the symphysis pubis. Here we demonstrated the ulnar border of the hand, feeling for the fundus of the uterus. So where's this uterus? There's going to be some sort of resistance. Where there's no uterus, there's not going to be any resistance to your hand. So you come from where there's none and gradually get into where you get the first resistance, and you measure that distance. Caution not to push your hands right up against the baby, because then you're not going to get the full fundus height. Remember, the fundus is part of the uterus and not part of the baby. So the first resistance where you feel fundus, and that's the measurement you take. If you plot that Symptoms of other height on a customized chart for the patient's ethnic origin and so on, you're more likely to predict a small for gestational age neonate. That's a baby that is smaller than the 10th percentile for its age. And if it's smaller than the 10th percentile, that's small. Or if we're getting that the growth is, falling, the percentiles are falling, or is static, or you're crossing the percentile, so it seems to be that the growth, there's no change in growth, right? Then that is an indication to assess the baby further by ultrasound to confirm whether your suspicions are true for small for gestational age or intrauterine growth restricted fetus. So how do we interpret this invasive other height in the absence of these growth charts? The conventional teaching is you take that measurement in centimeters, it should pretty much add back to the gestation once you've done that measurement over 24 weeks. And a bit of wiggle room, so if you go 2 centimeters over or 2 centimeters under, you're still within range. So you'd be probably small for dates if you're measuring less than more than 2 centimeters below, and large if you're 2 more centimeters be above. So for example, the 36 weeks, you expect to get 36, maybe 34 at the minimum, 38 at the maximum, and if you're outside of that, you're either small or large accordingly. Symphysis for night measurement might not be reliable if the woman has excessive abdominal fat, like in a large BMI, and she's got large fibroids, which might contribute to that measurement, and she's got a lot of fluid in the surrounding the fetus, like polyhydramnios and etc. So in such women, it's probably more prudent that you should do serial measurements of the fetal size, maybe every 4 weeks from 28 weeks or so, just to ascertain that fetal growth is occurring appropriately, because fetal hormone measurements might not allow you to detect a problem. Detectable hypertensive disorders in pregnancy. We mentioned first onset beyond 20 weeks to say that it's specific to pregnancy, and that holds here. Gestational hypertension, first onset during pregnancy, that's beyond 20 weeks. It should resolve after pregnancy if it's truly just gestational, as in only due to pregnancy. And absence of proteinuria would leave it at gestational hypertension, but should there be proteins in the urine, we now have preeclampsia, previously known as PET, or preeclampsia toxemia of pregnancy, which is a more serious and multisystemic disorder. Hypertension after 20 weeks, but that proteinuria as well. Again, because this is gestational or related to pregnancy, this resolves when pregnancy is over and the placenta is delivered. Just to reiterate, to diagnose hypertension, we need 2 readings, 140 on 90 systolic, diastolic respectively on millimeters of mercury, taken at least 4 hours apart. And to get the diastolic, if we're doing using auscultation, the Korsakoff 5 sound is used, or disappearance is used for the diastolic sound, not the muffling or Korsakoff 4. For diagnosis of proteinuria, the qualitative method would be the dipstick. 1 plus or more is significant, but as false positives can occur due to contamination with blood or discharge and so on, it might be a good idea to get further tests to confirm that this 1 plus is truly a significant proteinuria. So things like the gold standard we use is the 24-hour urine collection, where a quantification of protein more than 0.3 grams, or if you want to say milligrams, 300 milligrams in a 24-hour urine sample or more is considered significant and diagnostic of proteinuria. For lesser volume, if we want a spot sample, we can do what's called a spot protein to creatinine ratio, so a small amount of urine. And if they find that there is 30 milligrams of protein per millimole of creatinine or more, so 30 milligrams per millimole or more, that's also significant. So 0.3 30 right, so 300 milligrams in the 24 hours, and 1/10 of that 30 milligrams per millimole. All right, so 3 is whole. So every antenatal visit, we do blood pressure and urine because we are so afraid of preeclampsia and need to diagnose it early. And here is a quick overview of the management of pregnancy with preeclampsia. This again comes from a NICE guideline. It depends on the degree of hypertension, but we tend to admit all of those to hospital. From a 150 on 100 higher blood pressure, we tend to need to treat the blood pressure because obviously we don't want to reach the severe hypertension where you're at risk for stroking. Blood pressure, once admitted, is done at least 4 times a day. We tend to say every 4 hours on all wards. And you don't need to, once you've had sufficient proteinuria, to recheck proteinuria as the diagnosis is already made. Depending on the level of the hypertension, you would need to do blood tests for preeclampsia evaluation, such as full blood count, kidney function, transaminases, either twice per week for mild or moderate severe, 3 times per week. Now, to end some miscellaneous concepts, fetal presentation, which is basically that part of the fetus which is going to be presenting first in the pelvis. You don't need to routinely check for fetal presentation until you reach 36 weeks when you're going to plan delivery. And breech presentation, which is basically the baby's bottom over the pelvis, is relatively common prior to 36 weeks. Majority of babies will have turned to cephalic by here. So the proportion of babies that tend to be breech still at term is around 3%. So routine evaluation is not required until 36 weeks, where definitely you would check the presentation. And should a breech be found, then it's managed accordingly. BMI reassessment, 3rd trimester. If you had a booking BMI of 40 or more, that 3rd trimester leading down to delivery is a good time for them to see anesthetists and so on, so that problems can be anticipated and management plans instituted to minimize complications. So, for example, if a woman with this amount of weight needed an emergency cesarean section, it's kind of it would have been nice for the anesthetist to have had a plan in place. So, antenatally, and this consultation can take place so that things like problems with venous access, etc., can be anticipated or plan made for regional epidural anesthesia. If a pregnancy goes beyond 40 weeks, then final visit at 40 weeks is the usual time that you would discuss and arrange induction of labor. So the benefit of induction of labor at 41 weeks is a reduction in cesarean section rate. It reduces the risk of operative vaginal delivery, reduces the risk of fetal compromise, meconium staining, large babies, macrosomia, and also reduces the risk of fetal and neonatal death. Membrane sweeping at term. So this shows membrane sweeping is basically passing a finger through the cervix, through the external os or external opening, through the internal os or internal opening, and maybe doing a rotation or separation with that finger rotating of the amniotic membranes from the inside of the cervix. So here this shows before stripping, the membranes are applied to that cervix. After stripping, space. So that really releases local prostaglandins, which can help to stimulate cervical change and uterine remodeling, and perhaps increase the chance of spontaneous labor within 48 hours. Is the evidence. There's also some evidence that increases the chance of birth within a week, and there's no evidence of any association with any adverse fetal or maternal outcomes. So that, my students, ends our talk on antenatal care. Here are some useful references, and I thank you very much for your attention.